Share the screen once again. You can see the screen, right? Right. Okay. Just a minute. So, guys, you can see the screen, is it?
Yes, sir.
Yeah. Okay. So what we'll do is we'll do like this. I think we did a few MCQs last week. I mean, the last session, right? I told you that dermatology is a bit vast. Actually, there's a huge number of topics, but everything that I've made is like very important. Like every single question is an MCQ, and if you actually do this, whatever the number of MCQs I did, you don't have to read any dermatology henceforth. So I think the last time you got the recording. So this time I'm not sure whether you will get the recording, but we'll try our best to try to give it to you. And I think last time there was one. I was just going through the reviews and whatever was written from you all, the comments. So one person has said that it's a bit fast. That was that I taught, because the problem is we have very limited time, right? So I made it a bit faster so that this particular session is not for you to grasp everything, right? For you all to just get an idea, an overall picture about the entire dermatology, and for you all to go home and read each and everything that was said. Read in the sense, just listen. You don't have to read anything. Okay. So you got the last recording. So I just guided you that, you have to just, when you go to your work or whatever, whenever you have free time, just keep a earphone on you and just listen to that. That's all you need. Don't read anything apart from that. All right. Okay. So now, can somebody, like, yeah, so I don't want you all to answer this, because you all be very uncomfortable in answering it. It's okay, just somebody read it. I want everyone to read. There are around, I think, 40 to 50 questions remaining now. So I just want you all to read it. Can someone read the question and the options, please?
A 27-year-old woman
Mm-hmm.
who is 34 weeks pregnant presents with an itchy, blistering rash over her abdomen. Initially, she had a red rash around her umbilicus, but it later spread. What is the most likely diagnosis? Options are pemphigoid gestation, seborrheic dermatitis, polymorphic eruption of pregnancy, HELP syndrome, and Pomfalix.
Right. Okay. So now this is like this. Now you see, like, I think the MCQs I did previously had covered so many things. Like, for example, pediatrics, there are very limited ones that you need to know. Likewise, everything have just limited things only. Now, when you talk about pregnancy, you know that anybody, I mean, any adult can get any kind of dermatological problems at any point of time. But having said that, there are limited ones that are actually aggravated in the pregnancy. Okay. So whatever I tell you, when it's very important, I'll just tell you that it's an MCQ. Just take it in your mind. And when you see this again, when you listen to it again, it will be very easy for you. So there are just 3 conditions that you need to know, which are very, very prevalent in pregnancy, that increases, that aggravates in pregnancy. So one thing is something called, you see in that option, which is called pemphigoid gestation. And this particular condition, the answer here is this pemphigoid gestations, because there, I'll tell you why. So you see this, okay, I'll show you the ones previously. Okay. So pemphigoid gestation is actually, it is a very, very rare autoimmune disease. And if you see in the middle of the umbilicus, you see this kind of an oval shaped lesion, just like a tinea, right? You see the borders are so big, and in the middle, you see a very small blister. So pemphigoid gestation is something like a autoimmune blistering condition that starts from the umbilicus. Okay, starts in the umbilicus, and usually in the second and or third, usually second or third trimester, and it's a kind of a pruritic, right? It is pruritic, it's itchy, and it becomes a small, like a papule, then it becomes a vesicle, which is a water filled small lesion, and that becomes a bit bigger, which is called as bulle, right? So smaller version, vesicle, turns into a bulle. So like I said, often it starts in the umbilicus. That is where it first starts, and then it slowly spreads away, and throughout the pregnancy it will exacerbate. So one condition that you learned here is pemphigoid gestations. The next one, let's go to the one in the picture in the options. Why couldn't this be seborrheic dermatitis? You see the picture in this, the first one is seborrheic dermatitis. See, the name suggests, I think that day I taught you all, it usually comes in areas where there is very much rich in sebaceous glands, just like your scalp, behind the ears, just at the nasolabial fold, around your oral, your mouth, and your chest. These are the areas, even in your axilla and groins. See, these are the areas where the sebaceous glands are very, very rich, and you get kind of, all these scalings are there and severely itching, and it does not bring blisters. Like you see in this picture, in the middle of the umbilicus, you see a few blisters and bullae, which is not there in seborrheic dermatitis. So this is also not a condition that will increase in pregnancy. Maybe they can get any I told you, any adult can get seborrheic dermatitis even in pregnancy, but this is not a condition that will exacerbate. The second condition I told you that can occur in pregnancy, which increases, exacerbate, is the second picture you see. It's called as a polymorphic eruption. So what does it mean? This also, polymorphic eruption, by the name suggests, this also brings urticaria, itchiness, and they can have some plaque. Raised lesions are called as plaque. And you see this picture, the umbilicus is spared. It doesn't cause anything to the umbilicus. It usually starts in the sides, in the flank. And you see this striae, this abdominal striae, that is where they start. So anything like itchiness, any papules, any urticaria, and that's called polymorphic eruption, especially in pregnancy, itchiness. And the difference between this and the other one that you read, the pemphigoid gestations, is that the polymorphic eruption starts late in the pregnancy, kind of third trimester. All right. Okay. The next one that can occur in pregnancy is this last one. You see this pompholix, right? Pompholix is something like this. Usually a person, like, let's say childhood, they have got this atopic eczemas. So when they slowly get into the adulthood, that atopic eczema can aggravate and slowly stop. It goes down middle. When the person becomes a bit like middle adulthood, this atopic eczema around the body, this itchiness, what we call eczema, goes off. But in pregnancy, there are fewer number of times where this pompholic, you see the last picture, it can occur. The same eczema which is in the body can occur in your palms and soles. So how does it occur? Here you see a lesion, and that's, the lesion is like red. It's like wounded. So exactly what the person has, the person who actually, when it aggravates, you get a papule, dot like things. They start itchy. They scratch, and that the end result of that itching is this pompholix, which you see in this picture. This also can occur in the abdomen, but mostly pompholix is something that occurs in the hands, the palms, or the soles. So this is not the answer again. So the next option that you saw was HELP syndrome, the fourth option. HELP syndrome is something that is in the in pregnancy, that too in severe preeclampsia, right? Just before, hypertension, preeclampsia, and then eclampsia. That's the seizures and etc. So when there is preeclampsia, the person will have, like, the pregnant patient will have headaches, epigastric pain, etc. So many things. So during that time, they get something called HELP syndrome, which is hemolysis, and EL is for elevated liver enzymes, and LP is for low platelets. So this also can cause itchiness, right? Generalized itchiness. But the problem is here, the patient will have, like, generalized itchiness and very, very, not much of lesions. But if you see in this picture, you get these lesions only in certain areas, like tang wala vitrak, you get these lesions, right? So this is then again not HELP. HELP syndrome is always itchiness throughout the body, generalized itchiness, right? Okay, let's go to the next one, right? So can somebody please read this question quickly?
A 22-year-old woman present to her general practitioner with concerns about facial acne. She is conscious of her appearance and fears that her acne has worsened in recent months. She has no significant past medical history, nor does she take any regular medications. She has not previously tried anything for acne. On examination, she has numerous pustules, papules, and comedones across the cheeks, forehead, and chin. There are no nodules or scars. What is the most appropriate management option?
Right, good. So one small thing that I wanted to tell you in the previous slide. So whatever I explained to you, mostly like, this fembigoid gestations and polymorphic eruptions and even atopic eczema, which is very common in pregnancy, these three things, or even pompholics. All these things are quite like an autoimmune condition where if they ask you about the management, then again, it's nothing but emollients. Emollients is to keep the area moist. When you get dry lesions, that's when you get itchiness. So you keep it like, moist by using emollients and steroid creams. And very, very rarely you need oral steroids. It can get better with steroids. And I have in my previous lecture, just listen to that, I have given you what are the type of steroids, what is the mild, what is moderate, what is severe, right? So I don't want to repeat that. Just go and see so that you'll get an idea. What do you use for the palms and soles? What do you use for the face? And what do you use for the body? I'll quickly give a summary if someone hadn't attended the last lecture. So the ones that you use in the face, in your axilla, and the flexures like groins, okay? These need very, very milder version of steroid, and hydrocortisone 1% is the mildest form. And some people still use something called mometasone in the face. You don't use that mometasone. You use only the milder one, which is hydrocortisone 1% for the face, axilla, groin, etc. Right. What is the moderate one? The ones that you use, I mean, throughout your body, like the entire your legs, your hands, and all around your body. You use the moderate one, which is betamethasone. That is betamethasone valerate 0.1%. And the ones that you can use for the palms and soles, just like how you saw the pompholics, you use not a moderate, a severely potent, which we call as clobetasol propionate 0.01 or 0.05%. You read my, just listen to my previous lecture, you'll get an idea, right? So coming back to the acne vulgaris, you just see this acne vulgaris. This is also the one that I taught you previously. Acne is a very common condition that you get, and all the reasons, all these things I've given you previously. So let's talk about this management only. Here, when you see this examination, it says numerous pustules, papules, and comedones around the cheeks and forehead. So, and no nodules and scars. So then again, acne, you categorize into mild, moderate, and severe acne. When you get just mild comedones and, mild papules, you categorize that as milder form. When you start getting pustules and this kind of, lesion where the patient is so embarrassed or so it causes discomfort, it becomes a moderate. And when it causes a lot of scars and huge nodules around the face, that becomes severe, right? How do you start the management in acne? I told you, whenever you start, the simple mnemonic is something called AB, and then it becomes a BC, and then you say at TC. What is AB? You always start with, you initially start with adapalene. Adapalene is a type of a retinoid which is used only at night. And AB is benzyl peroxide, which is not an antibiotic. We can call it as an antiseptic for this. So you start with AB, one combination. You increase that for around 4 to 8 weeks. It doesn't get better. Go to the next option, which is BC, that is benzyl peroxide, and you give 1C. C is you give a clindamycin gel or a cream. So here, one important point that you need to know, I have already explained, so I am not going more on acne. Always remember what we do, the mistake we do is we combine a clindamycin cream and an oral antibiotic as well. Remember, when you give two antibiotics, one oral and one in a local application form, the patient will get resistance. So never, ever give an antibiotic with, in the sense, oral antibiotic with a cream. So here in this options, when we go, oral isoretinoin is not the option. Why? Because that is given only in severe acne when the patient is having a lot of scars in the face or huge bumps, which we call nodules. So this severe acne, you can give oral isoretinoin, not in this case. And that too, isoretinoin MCQ, isoretinoin is given only by a dermatologist. It's not given by a GP. If you need to give isoretinoin, refer the patient. MCQ. Next, when we get back to the oral limicycline, okay, which is then again a type which falls just like doxycycline, okay. So here we don't give only one antibiotic or only one oral. We always combine that with the local application as well. So the third option, oral limicycline with topical acylic acid, is the answer, because acylic acid is also just like adapalene, just like a retinoid. Those are given only at night. It is not an antibiotic, so you can safely give one oral antibiotic, either a doxycycline or limicycline. Then the NICE guidelines always recommend limicycline right now as a first line. So this is the answer here. And the next one is oral benzoyl peroxide. It's not given in acne. It is given only in impetigo. I think those days we have read that impetigo we give as a first line. You give local application of some antibiotic like fusidic acid. And if the patient is having like MRSA, right, methicillin resistant Staph aureus positive wounds, then you give mupirocin local. But the recent NICE guidelines MCQ, first line for impetigo is topical benzyl peroxide. So that is also not the answer here. At the end, topical clindamycin, yes, can be given, but always combination is better. I just told you AB, BC, TC. That's the combination. You can give something of this, and if it doesn't work, add an antibiotic, which is oral. Never give oral and a local together, right? Okay, let's go to the next one. Right. Can somebody please read this? Yeah, quickly.
A 24-year-old man comes to see you concerned regarding the recurrent painful lumps and boils in the axilla and groin region for several months. The patient has previously seen dermatology and was diagnosed with hidradenitis suppurativa. On examination, there are multiple small painful nodules in the axilla and the groin region. Heart rate is 68 beats per minute. Tympanic membrane is 36.4 Celsius. You suspect recurrent hidradenitis suppurativa. What is the next most appropriate management step?
Right. So the topics that I have given to the entire day today and the previous day are so important that never miss that. You just do this. You can answer. I think you will at least get 5% of your question is going to be on dermatology. You can easily ace this if you know this. Okay, right. So this topic, you know about, I mean, the answer itself is given here in the third line that it is hidradenitis suppurativa. Okay, right. So knowing about this, you know that hidradenitis suppurativa, you get, lesions in your axilla or groin region. And one important thing is that what we do is when we get an infection, in the axilla, we just treat for 7 days or maybe maximum 10 days. But you have to know it's very important. Surgery is not the only option here. We can still manage the patient with oral antibiotics, but the oral or topical, whatever antibiotics have to be given for a longer period of time in this hidradenitis suppurativa, right? So, like you see the first option, they talk about topical steroids. You should know topical steroids is not given here, but there is a small, possibility you can actually think of giving intralesional steroids if it becomes very severe, but no topical in hidradenitis suppurativa, because that is also kind of an infection in the sebaceous glands, just like something like your acne in the face, right? So you never give steroids, so steroids is out of the picture. But is the second option, commence the patient on topical clindamycin for 3 months. That is the real answer, because you either give topical clindamycin or you give oral doxycycline or oral limicycline. See, it's so similar to the acne, right? So you give, this is the option that you can give for a patient. And remember, if you get a hidradenitis suppurativa, if you suspect, because initially any lesions on the axilla, we treat like something like a folliculitis, right? That's what we treat like. So we treat for 7 days, but remember somebody coming to you with repeatedly again, lumps and bumps and nodules and pus coming out of the axilla, always suspect this hidradenitis suppurativa, and you give antibiotics for a longer period of time, either local or orally. So the third option here is commence the patient on topical retinoids. Like I told you, oral or topical is given in acne, though this is also a type of acne. It's not even given even for a severe whatever hidradenitis suppurativa. Topical or oral retinoids are not given. Right. Next, inform the patient the only cure is surgery. The fourth option, false. I just told you, surgery is not the only option. You can still think of oral or topical antibiotics for a longer period of time. That is the management. And commence the patient on emollients, which is the last option, is not the answer. I told you emollients are given for most of the conditions in the skin just to make it moist. That is the only, I mean, reason that you need to give emollients, right? Okay. Now, shall we talk a bit of hidradenitis suppurativa? Okay. So, see, this is a MCQ point, okay? You should know every point that I tell you. Don't worry. We'll try to talk to the organizers of this lecture and try to give the audio lecture of this or whatever the recordings, because I might be a bit faster, but I'm trying my best to just make you understand what these things are, so that when you again read my, go through my lectures, like listen to it, everything is going to come in your mind, right? Okay. So this is a chronic, painful, inflammatory skin disorder. All 3 points are very important. And like I told you, they can get nodules, small dot, and those dots can slowly become, a bit bigger with a lot of pus, which we call as pustules. And those can, interconnect with each other, causing sinus tracts. So mostly it occurs in your groin and axilla, very important. And any patient who is in the pre-pubertal or pubertal age group who are coming with recurrent boils, and like I told you in the axilla or groin, please suspect that. And one important another MCQ, women are very likely to develop this than men, and mostly it occurs in people under 40 years, right? Under 40. The risk factors, very important. You need to know the family history. They can run in families, smoking, obese patients, diabetes, polycystic ovarian, and people who do kind of a mechanical stretching of their skin, right? Suppose they go work out and then they stop working out. This, after stretching, you get this condition, and that is one thing. Like I told you, the clinical features are you get a recurrent, painful, inflamed nodules. Axilla is the most common region, and I told you how it occurs, these nodules, and it bursts and all those things I told you. Now coming back to the diagnosis. So there is no any particular diagnosis. It is a clinical diagnosis, MCQ, right? The next one, how do you manage this kind of patients? So first thing, you need to tell them that good hygiene, shaving that area, very good hygiene, and do not wear any tight clothes onto the axilla, very loose fitting clothes. Please stop smoking. Weight loss if the patient is obese. And like I said, long term, you can use like clindamycin for a long time, or oral limicycline or doxycycline is the drug of choice. And if you have some big lumps not getting better for oral, that is when you need to refer the patient for surgery, right? Right. Okay. So this is how it comes. You see lots of kind of multiple opening tracks, like sinus tracks. And if you see, I can notice one small thing. In the axilla, when you talk about the kind of 9 o'clock position, you see some small lesion starting from the 7 o'clock position going into the 12 o'clock position. That is nothing but a striae. So that's why I think most likely this patient would have had a steroid cream, right? And that side effect of the steroid cream is what you see on the screen, because probably the person who has prescribed didn't know the diagnosis, just started steroid, or maybe using something like I told you, betamethasone on the axilla, because I told you axilla, face, groin, all the soft areas you need to use only hydrocortisone, which is the mildest form. So using betamethasone or clobetasol in these areas can cause this triad, right? Can somebody read this now, please? Don't waste time. Anybody just switch on your mic. I'm just telling you to read only. No need to answer.
24-year-old man presented with a swollen, itchy right eyelid. This has been ongoing for 10 days, but the patient reported it has happened at least 5 times previously. Each time it's self-resolved. On examination, there is erythema of the anterior lid margin and the base of the lashes of the right eye. Visual acuity, fundoscopy, and cranial nerve examination are normal. To perform a systematic inquiry to elicit an underlying cause of this recurrent condition. What is the most likely underlying condition? Atopic dermatitis, psoriasis, rheumatoid arthritis, rosacea, seborrheic dermatitis.
Right. Okay. So, sorry, certain things that I actually explained in detail, I'm not going to do that because I've already did it in my last lecture and you have the recording. So if I repeat, I'm going to waste time and we're going to miss a few MCQs. So I'll just quickly touch upon only the options here and the things that I have not explained. Okay. So if you see this condition, I just explained to you, right? Something in the eyebrows, nasolabial folds, right? So this condition, can't you see it's very, very likely going towards seborrheic dermatitis, right? So this condition is seborrheic dermatitis. You see, I told you only the areas where there is sebum rich behind the ears, nasolabial, the oral, and around the eyes. If you see this patient, you see around the eyelid margins, it has become reddish, inflamed, and a bit crusted, right? So what do you mean by that? So this particular patient is having seborrheic dermatitis, which is the fifth option over here. And what has actually happened to this patient is that the patient has got something called phlebitis. What is phlebitis? Inflammation of the eyelid margin. Because all this, the patient will scratch their head, lot of dandruff. All this dandruff falls on these kind of areas and even the eyes, and that causes this kind of inflammation. So one MCQ point that you need to know, what is the what is the most common complication of seborrheic dermatitis? Number one, phlebitis. Number two, it is otitis externa. What do you mean by otitis externa? Infection or inflammation of the external auditory meatus, the external ear, right? The external ear. Why? Because like I told you, behind the ears can be affected in seborrheic dermatitis. Patient will scratch, or the dandruff falling onto the ear and going and causing infection. These two conditions, MCQ, is the complication of seborrheic dermatitis. Right. Next, why cannot it be atopic dermatitis? I just told you. What do you mean by atopic dermatitis? The simple eczema that you all know, right? So it can affect the face, atopic dermatitis, but face is usually affected in children. So atopic dermatitis, you need to know the various stages, how it causes in, where and all it causes in different age groups. So atopic eczema, like the name suggests, kind of a autoimmune, or it can run in families. It starts, mostly it starts in childhood, infants. How does it start in infants? In the face, all your cheeks, these kind of areas, that's where it starts. When the child slowly grows up, goes to school, preschool, kind of school to preschool, school to, preschool to school, that age group, probably 10 or 12 years, it slowly comes to the, which area? The flexures, psoriasis causes problems in the extensors, right? Right. But the opposite you see is in atopic eczema. So the child usually get into the face and slowly it becomes a lesion in the flexures. In between that, the patient or the child can get it into extensors. So remember, face, extensor, flexor. That's how it goes. But in contrast, you see the psoriasis, mostly it occurs in your knees or your elbows. So all these extensor regions. So atopic eczema in adults is opposite of psoriasis. But in children, it is the opposite of the adults, right? You understood. So atopic eczema, then again, I'm repeating it. Children, it is in the face, slowly goes to the extensors, and school age, it goes to the flexors, right? So that is why this is not the answer, because this person you see is a 24-year-old man, grown-up man. It's not going to happen in the face. Next, rheumatoid arthritis. Why did they mention rheumatoid arthritis in the option? Is because rheumatoid arthritis can cause ocular problems. It's an MCQ, right? The ocular problems that it can cause is episcleritis or scleritis. The whitish area of the eye, I think someone would have taken eye lecture. So the whitish area becoming inflamed is scleritis. And something that, like, I mean, the layer that is on top, the topmost of the white, episcleritis, then becomes scleritis, and then there's something called keratitis. Your entire cornea, right? Now you know the whitish, also the whitish areas can have problems in rheumatoid arthritis. Next is keratitis, that is the cornea can have ulceration, inflammation, etc. These four are the main things that can be caused in rheumatoid arthritis, not phlebitis. So that's why this answer is wrong. Next, number 4, acne rosacea. That is also a type of acne that can happen in the face. I explained everything about it. I'm just going to say why this is not the answer here. So acne rosacea also can cause problems in the nasolabial fold, nose, everywhere in the face. But usually what happens? First, in acne rosacea, you get flushing. The entire face becomes red, inflamed. That flushing slowly turns into reddish erythema, and that causes small papules and pustules, and then telangiectasia. What is telangiectasia? A small dot, and there is small veins coming out of those dots. That is telangiectasia. So here you don't see any of the features. So acne rosacea is not the answer here, right? So you see this, I told you atopic dermatitis, I just explained, you get mostly in the flexors. Number 2, on your right side, psoriasis, mostly in the extensors. Number 3, rheumatoid arthritis. I've just given you some kind of vasculitis here, but I have not mentioned about the eye, but I told you what are the eye conditions that rheumatoid arthritis can bring. Number 4, rosacea. See, can you see small lines going around there in the middle? That is the telangiectasia, and the reddish is your erythema. So this is not the answer. The previous one is seborrheic dermatitis, right? Can someone quickly read this one?
A 76-year-old woman presents with a painful erythematous rash across the right side of her chest. It started this morning, and he describes a sharp burning pain on his chest wall 24 hours previously. On close examination, there are vesicles present and the rash does not cross the midline. He is prescribed antivirals and follow-up is arranged. What is the main advantage of antiviral treatment in this patient?
Right. Go ahead. Yeah. Tell me the option. Yeah.
It reduces the contagious nature of the infection. Second, it reduces the incidence of the post-herpetic neuralgia. It reduces the pain. It treats the infection and prevents recurrence. Prevention of secondary infection.
Okay. So this is just a very small topic. It's so important. That's why I gave you this particular question. So I think once I got this for my MD selection, I think, so many years back, 3 or whatever years back. So the answer here is when you're getting shingles, why do we give antiviral treatment, right? Okay. So we might think that, okay, that's actually going to get the person better. But the actual answer here is, let's talk about the first one. It reduces the contagious nature of the infection. That is not the answer here. It does not, does not decrease the spread or anything. Only thing that it can actually reduce is the incidence of the post-herpetic neuralgia. You have to know that even the spread of infection, pain, secondary infection, nothing it will prevent. Very important MCQ. That's why I put this. It's the only thing you know is very common complication. Which one? Once you get shingles, the person getting post-hepatic neuralgia is very common because it can cause significant pain thereafter. So that is the only reason why you give this post-hepatic these antivirals for shingles, just to reduce the incidence of post-hepatic neuralgia. Despite giving antivirals, still let's say that the patient is having post-hepatic neuralgia, then is where you give neuropathic drugs. And the first line is either you give amitriptyline or you give duloxetine. These two, according to NICE guidelines, are the first line given. Either you can give either of the two. Anything is given as first line, one or this. Either you try with amitriptyline, doesn't get better, then you give duloxetine. If it doesn't get better for that, also the second line for neuropathic pain is tramadol, and that is an MCQ. Okay, so don't forget that. And did I miss anything? Prevent secondary infection. Okay, that is done. Okay, that's about it for this MCQ. Just know that why it is given: not to prevent infection, not to prevent the contagiousness, not to prevent the pain, just to reduce the incidence of post-hepatic neuralgia. Right. So this is the shingles, and you know that these shingles are usually at one dermatome, never cross the midline, just from one side to the other. Midline doesn't cross the other side, just one dermatome. Right. Can somebody read this, please?
59-year-old man asks you to have a look at a white patch on the inside of his mouth. It has been present for around 9 months. What is the most appropriate management? Prescribe chlorhexidine mouthwash and review in 2 weeks. Prescribe oral metronidazole and review in 2 weeks. Advise him to see the dentist. Refer to head and neck services. Prescribe nystatin.
Right. Okay. So when you see this kind of white patches in the mouth, then again, three differential diagnoses should come in your mind. One, is it candidiasis? Number two, is it lichen planus? Number three, is it leukoplakia? So if this white lesion can be easily scraped off and just it will come out, then you know it's candidiasis. And if it's not scraped off, then it is most likely going towards leukoplakia. And if this oral lesion also comes with lesions on your skin, right? So skin plus oral mucosa lesions, always suspect lichen planus. So here they're talking only about the white patch which is inside the mouth. So it is very typical of leukoplakia. And whatever I'm discussing, I'm not going to tell everything about leukoplakia, only MCQ oriented, right? So what is leukoplakia? You know, it's a pre-malignant condition which usually presents like these white spots and, kind of very hard in the mucosa inside the mouth. And it's very common in smokers. And so leukoplakia is something like a diagnosis of exclusion. Like I told you, always consider candidiasis and lichen planus. And if you have excluded all these, the two, then you think that, yes, it is leukoplakia. It is a pre-malignant condition because it can turn into a squamous cell carcinoma, but the incidence is 1%. Just 1%, it can turn into a squamous cell. And that malignant transformation, just because you need to exclude that malignant transformation and exclude that this is whether it's a leukoplakia or not, you need to refer for a biopsy. So out of these options, prescribing chlorhexidine mouthwash, no, this is not some aphthous also anything like that. Prescribing oral metronidazole, no, it is not gingivitis or it is not any oral ulcer. Advise him to see the dentist, no, that is not okay, probably to clean his teeth. But the fourth one, refer to head and neck services, yes, to do a biopsy because you have come to a conclusion that it is leukoplakia. And the last one, prescribe nystatin, no, because this is not candidiasis. Right. Somebody please read it. Read this now. Please, don't waste time. Yeah, please, somebody just read this. Yeah. Please read it. I mean, there are 62, you know, I mean, no, I mean, there's, you don't have to worry about the answer. Just read it.
A 17-year-old male presents with a new skin condition which his mom noticed when they were on holiday in Spain. On examination, he had skin type 5 with multiple small patches of depigmentation to the upper back. The patches appear mildly flaky, but they are asymptomatic. He is usually well and has never had this condition before. Which of the following is the most likely diagnosis? Pityriasis rosea, atopic eczema, vitiligo, guttate psoriasis, pityriasis versicolor.
Right. Okay. So you see, they are talking about these conditions. The patient has gone to a holiday in Spain. And so you know that, okay, probably there's some sun exposure and multiple small patches. It's depigmentation. You know, there are 3 types of pigmentations, which is hyperpigmentation, like, you know, so black, which some people have something called melasma, so much of melanin, that is hyperpigmentation. And then there's something called depigmentation, no pigment, no melanin, it's so white in color, that is vitiligo. And then something called hypopigmented, right, which is seen in this condition. So most likely, I'll show you the pictures. So this particular condition is pityriasis versicolor. I think I explained it to you last time, so you can just go and read what it is. I'll explain whatever is there in the options. See, there were options called atopic eczema, pityriasis rosea, vitiligo, and guttate psoriasis, which is very, very important in the exam-oriented thing. So what is pityriasis rosea? You have to know one thing. See, pityriasis rosea is something like a small oval-shaped lesion which looks just like a tinea, right? But why isn't this tinea? Because tinea is something that is, you know, it will be there in a patient for a long time. But pityriasis rosea is an acute condition. It's a self-limiting condition. And this, what you see, is how it starts in the body, usually either in your hands or your entire trunk, the front or the back. This kind of patch is caused initially in pityriasis rosea, which we call as herald patch. MCQ. Herald patch is the first thing that is caused in pityriasis rosea. That's how we actually try to diagnose it. Okay, so like I told you, it's an acute condition, and there is no any particular cause as to what is the reason behind this. But if you see majority of the patients, you see this kind of 1 or maybe maximum 2 or 3 patches in the body like this. When you talk to them, majority will say, yes, doc, probably in the recent 1 week, I had a viral prodrome, a viral infection. After that only I got this kind of patch, which is called as herald patch. After this herald patch, this small oval lesion slowly kind of increases in intensity. And if you tell the person to remove their shirt at the back, you see something called this entire pattern follows a kind of a Christmas tree. So what we call as a fir tree appearance, FIR, fir tree in the entire trunk. If you see something like this, these lesions will increase starting in the back, just with 1 lesion, then it becomes 2, then the lesion on the back, fir tree. That's called pityriasis rosea. So I'll talk all about pityriasis rosea because I didn't tell about this. So you know it's a self-limiting condition. Do not treat pityriasis rosea. The patient will get better in 6 to 12 weeks. 3 months, the patient is all right. Okay. What is the differential diagnosis for pityriasis rosea, which is another condition, and an acute condition which will just go off is guttate psoriasis. You see the 4th one in the picture, right? This thing also is in the back. Mostly you can get in the trunk or the hands, but mostly in the entire trunk, you get small psoriasis kind of lesions. How? Silvery scales, the reddish inflamed patches. There are a lot of silver, whitish patches, and that is your guttate psoriasis. Both the conditions are acute. Both the conditions are self-limiting. So what is the differentiating factors, right? If you see guttate psoriasis people, they say 2 weeks prior to this lesion, I got some sore throat. So that is a streptococcal sore throat, maybe 2 weeks, prior to that. And then the lesion, that is gutted psoriasis, just a viral prodrome. And then you get the lesion, that is your pityriasis rosea, right? So what is the appearance? I told you it starts with herald patch, the pityriasis rosea, roundish oval, then increases, and then fir tree appearance in pityriasis rosea. But in gutted psoriasis, if you see, these are small dots. And the typical wording, the MCQ point is teardrop appearance. Small tear, yeah, the water drops, teardrop appearance is typical in gutted psoriasis. And this also most commonly happens in your trunk and the limbs. And you know, pityriasis rosea, self-limiting, gets better in 6 to 12 weeks. But in contrast, here, gutted psoriasis, also around 12 weeks, but from 8 weeks itself, they'll try to get completely better. So pityriasis rosea, 6 weeks to 12 weeks. Gutted psoriasis, mostly 8 weeks, but it can extend up to 12 weeks, right? So vitiligo. Vitiligo, with the as the name suggests itself, you get kind of completely no pigmentation. That is called as depigmented, no pigmentation at all. And it becomes so white because the entire melanin component goes zero. There is no melanin in that area. It's due to an autoimmune condition. And the first line that you can give in the vitiligo whitish areas, you can actually use betamethasone cream, because this is an autoimmune condition, and use it for 4 to 6 weeks. And if the patient doesn't get better, you can use immunosuppressants like tacrolimus cream, or you can add some oral steroids in a pulsed fashion, like oral dexamethasone. You can give it for like 5 days, take a break for 3 weeks, and then again start the pulse therapy for vitiligo, right? And atopic eczema, like I told you, it's just the normal eczema where you tell the patient to use emollients, keep the area kind of moist, not dry, and then use steroid creams. It depends on which area you're using. In the picture, number 2, the option 2, you see it is in your flexors, that is your, elbow, your flexor in the hand. Here, since it is flexors, you do not use any potent, you use only the mild version, which is hydrocortisone. Right? So that is why this is not the option. And did I miss anything? Right. 1 second. Okay. Fine. Okay. So pityriasis, like I told you, this condition is pityriasis versicolor. And why it is pityriasis versicolor? I told you seborrheic dermatitis and pityriasis versicolor both are from the same group. The fungus which is responsible for both MCQ, it's called as Malassezia fur. That is the causative agent for both pityriasis versicolor. So in Sinhala, we use that word called aluhang. So aluhang is the pityriasis versicolor. Either you can get kind of, light patches like this in the picture, or you can get dark brown in color. And what is the treatment that you can use? Then again, just like your seborrheic dermatitis, we try using antifungal shampoos. Tell to use it for 30 minutes, and then wash it off. And if it doesn't get better with that, you can probably use a very mild steroids, number 2. And number 3, you can use oral antifungal just for 1 week only, right? Then again, I'm just recalling what we studied previously. If you get if you get a fungal infection on the nail, that is onychomycosis. If it is the fingernails, you use a pulse therapy for 2 months. And if it is a toenail, you use it for 3 months. I've anyway explained this previously, but I'm just giving you so that you'll have an idea how many weeks you need to use antifungals. And whatever antifungals on the body, like for example, you get tinea corporis, any fungal infection on the entire body, apart from the scalp and the nails, we actually increase the duration from 6 to 12 weeks, up to 3 months, we might have to give, right? So can we go to the next one? Can somebody please, this one I've anyway explained to you, it's very easy. Can somebody read this, please?
A 23-year-old man present to your clinic complaining of a rash that has spread suddenly over the past 4 days. Upon further questioning, he explains it started with one patch on his leg. He is otherwise well, but admits to having had a mild upper respiratory tract infection a week ago. What is the most likely diagnosis?
Actually, I don't know who's reading this. I don't know your name, but I don't want to actually ask any answers from you all. I would love to teach you, but since I just explained right now to you, something causes an issue after a mild respiratory tract infection. I just told you. If you're okay, you can answer what this is.
Pityriasis rosea.
Excellent, very good, very good. So I think my teaching has actually gone somewhat to you. I'm very happy. So in the options, why they have mentioned eczema and tinea corporis is because any oval lesions, round lesions in the body elsewhere, anywhere in the face or your body, trunk, skin, hands, legs, anywhere, there are very limited differential diagnosis. It could be what? Lupus, that is something to do with an SLE, oval lesion. Number two, it could be an eczema, that is also oval lesion. It could be pityriasis rosea or tinea corporis. Why this is not tinea corporis? I just explained to you what is tinea corporis. A fungal infection that is in the body, entire body, except your nails, face, and your scalp. So why this is not tinea corporis is because tinea corporis, if you see this picture, entire herald patch is similarly affected, same. But if you see tinea corporis, the previous pictures I think I've shown you, only the outer border, the outside circle is only elevated, while the middle one is completely flattened, which we call as central clearing, right? Okay, great. So Pityriasis rosea, you gave an amazing answer. So can somebody quickly read this? It's a very easy one. We'll try to finish this.
A woman consults you regarding skin lesions on her chest. On examination, there are two similar lesions, each a tiny red papule with a visible fine vessels surrounding it. The lesions blanch on pressure. Which common medication may be responsible for the lesion? Furosemide, sitagliptin, simvastatin, combined oral contraceptive, nifedipine.
Right. Okay. So the one that you see in this picture, I just explained previously to you something that is like, a rounded small papule in the middle, right? A red papule and small branching capillaries going away. One is telangiectasia, the other one is spider nevi. These are the only two differential diagnoses. So this lesion, okay, both the lesions, telangiectasia and this spider nevi, they both blanch on pressure. You just press it and leave it, it will come filling. So how do you differentiate between this and telangiectasia? See, in the center, there is a small kind of a papule, right? And when you actually, completely completely blanch this lesion and take your hands out, this small veins, they try to fill from the center outwards. If it fills from center outwards, then it is spider nevi. And if it spreads, if it again comes, the filling comes from the outside to the middle, out to the middle, it is telangiectasia. From the center to outside, it is spider nevi, right? So where do you get this lesion? So 10 to 15% of the people, like people in the community, one or more spider nevi, they definitely have, which is very common. You don't have to do anything. That is one MCQ, okay? 10 to 15% are common. Children, it is very common, it's very benign, but the ones that you have to worry is liver disease, pregnancy, and combined OCPs. You have to ask the patient, are you on combined OCPs? These are the three things that you have to worry about. So the options over here, combined OCPs will be the answer. All others are negative, right? Can somebody please read this? It's very important. And you can see, as the picture suggests itself, It's quite easy. Can somebody please read it? Yeah. It's very, very important. I mean, yeah.
34-year-old man presents with a scaly rash on his elbows and knees that has been getting progressively worse for the past 3 months. He has tried using some of his wife's emollient cream, which has helped the itching somewhat. Following NICE guidance, what is the most appropriate next step in the management? Topical potent corticosteroid plus vitamin D analog. Topical potent corticosteroids. Refer for ultraviolet light therapy. Topical vitamin D analog. Topical Colta.
Okay. So with the picture suggests, I just told you right now, extensors are affected, erythematous base with silvery or whitish small dot areas. It goes very typical towards a psoriasis, right? So this particular condition, okay, the patient has been having it for a long time, scaly, and it has become worse in the last 3 months. So probably this is a chronic plaque psoriasis, right? So they're talking about the management here. So you have to know now, all the answers I'm giving you is from the NICE guidelines, which is very, very important. You can answer all these things in your, MCQs, right? Because so many areas, they give different sorts of management, but it's always better that you follow one guideline, and NICE guidelines is more than enough. And that's very important even for your local exams here, right? So chronic plaque psoriasis, what does NICE guidelines always recommend? Number one, use emollients. That is, there's no doubt in that. Why? To keep that area a bit moist, because being a bit dry can cause kind of itchiness, so much of scaling, and that tissue is going to, that skin is going to lose. You're going to lose that skin. So put emollients. That is not the treatment. That is just an additional thing. And the number one treatment, use a potent corticosteroid. That's a steroid. Potent, I told you. So it's not mild, potent. So it can be betamethasone for these kind of lesions, and severely potent, which is clobetasol in your palms and soles. So start with the potent corticosteroid, the steroid, plus you give a vitamin D analog like calcitriol. I will tell you why it is used. So calcitriol is a vitamin D analog. You give both these. Not most of the, dermatology, it is either one cream you use, but acne, I told you, you give a combination. Likewise, psoriasis, you give a combination. You start with a potent steroid, and in the morning and in the night, you give a vitamin D analog. You need to give this and use it for a period of 4 weeks and see. 4 weeks, it doesn't get better, stop, and then go to the second line. What is the second line? Now, first you gave already steroid and vitamin D analog combination. One in the morning, one in the night. Number two, it doesn't get better in 4 weeks. Then you try only one that is only a vitamin D analog like calcitriol given twice daily now. Previously, we gave only once. Now you give twice daily, and then again you increase it for around 4 to 6 weeks, or maybe even 8 weeks, and try and see it doesn't get better. Then what you do, you use only a steroid, then again twice daily. So first, morning steroid, in the night vitamin D. It doesn't get better in 4 weeks. Next, you give only vitamin D twice. Doesn't get better in 8 weeks. Third line, you go for steroid only twice daily. And then what you can do, if it then again doesn't get better, the last option is Colta. Colta is not the first one. It is the last option that you go, even if it doesn't get better with steroids. Okay. Now, let's say that the patient is probably getting better. What is the second thing that you can give? Because number one, local application done. Number two, what you need to do is you can give some phototherapy. Phototherapy is so important. It's very like, it gives you this PUA. PUA is the one that we use here. It gets you the ultraviolet B rays, and that rays going into the skin condition can get all the immune, because it basically you need to immunosuppress that area, right? That's why you use steroids, and that's why you're using the phototherapy. But you have to be very careful. MCQ point, when you use phototherapy, the side effect that you can get is squamous cell carcinoma, not melanoma. Squamous cell carcinoma, you get as a side effect from phototherapy. Number 3, let's say phototherapy also didn't get better. The patient is having a severe widespread lesion. Then you consider something like systemic oral. What is the oral one you give? Nice guidelines recommend you to give oral methotrexate as the first line. First line oral methotrexate, and then the second line, if it doesn't get better, you use cyclosporin. If it doesn't get better for that also, then you think of biological agents. I'm not going to explain the names and all, because just know it's biological agents, because when you get an MCQ, you will know what the name is. You get some infliximab and rituximab and etc. Right? Okay. These are all for the lesions in the entire body, right? Your trunk and your hands and your feet and legs, everywhere. What if you get in the scalp? MCQ. So in the scalp, what you need to use is, now scalp is a thick skin, just like your palms and soles. So here you can use a potent one, which is a maximally potent one, like clobetasol. Maybe you can even use a moderate one, like a betamethasone also, and use it daily for 4 weeks and see for the scalp. Do I have a picture of scalp? No, right? Okay. So scalp psoriasis, I think I repeated again, I'll tell you, if you get some lesion, the same pinkish lesion in your hairline, if it comes below the hairline, crossing the hairline, it is psoriasis. And if it doesn't cross the hairline, it is seborrheic dermatitis. Why? Only it happens in the sebum-rich areas, seborrheic dermatitis. So in your forehead, you don't get this sebum. So you don't get the lesions in seborrheic dermatitis. But if the lesion in the scalp spreads towards your forehead, that is psoriasis, right? So 4 weeks you use for scalp. It doesn't get better in 4 weeks. Then the same steroid, you use it in a different formulation. For example, initially you use creams. After 4 weeks, it doesn't get better. Then you can use either shampoo or lotions or spray. That's how you use, right? Next, we are done with the scalp psoriasis. We are done with the body psoriasis. Next, coming back to the flexures, like, groin and axilla. I told you, use only mild steroid like hydrocortisone 1% and not more than 2 weeks. Please remember that. Scalp 4 weeks, other areas 8 weeks, flexors 2 weeks, right? So I told you, then again, when you are using any kind of steroids, right? Any kind of steroids for more than, let's say, 4 weeks, if you think you're going to use, you need to take a break after 2 weeks. After 2 weeks, what you do is try to see if you need to reduce the frequency. And after 4 weeks, like at the end of 2 weeks, you analyze and see. And the end of 4 weeks of local application, please take a break for another 1 to 2 weeks, and then again use it henceforth or further from that, right? I told you about the vitamin D analog that is given in the first line, calcitriol or calcitriol. Those are the two things that you give as vitamin D analog. So you might think, how does vitamin D analog works? Because steroids work by reducing the inflammation and reducing the autoimmune response. But vitamin D analog, how it does is, basically these cells are proliferated, right? It becomes big. It becomes, the cell is divided, so many cells. So vitamin D decreases the cell division and the differentiation. And like I told you, the adverse effects are very, very less compared to the steroids. Why? Steroids, you just saw in that picture, hidradenitis suppurativa, you just saw that there was striae, right? So when you use steroids for a longer time, you can get striae, you can get, a kind of atrophy, skin atrophy, those things. But in vitamin D, you don't get. But in coal tar, you can get problems like what? It is tar, it is black in color, it will smell or it will stain their clothes. You have to be very, very, careful. And one MCQ point, vitamin D analog not given in pregnancy. Remember, that's a very important MCQ point. And anything else did I miss? Right, okay, yeah. One more thing. You have to know this vitamin D, right? Vitamin D analog, what it does is, it will not bring down the erythema. This redness will not go, but the thickness and the scaling will reduce from vitamin D, very, very important. Okay, right. So like I told, this coal tar, it will stain in your body. So if at all it's staining your body, please wash it off in 30 minutes, right? Okay. Can somebody read this now? Don't waste time, no? We have less time. Just read it, please.
Your boy presently come to see you regarding his troublesome dandruff. More recently, mom has noticed a patch of hair loss at the back of his head. On examination, there is widespread scalp scaling, and the skin appears scaly and inflamed under the patch of hair loss. What do you do?
Right. So the options here are advise coal tar shampoo. If you see coal tar, I just told you it is given in case of psoriasis, but here it doesn't look like psoriasis. The lesions are probably only inside the scalp, so the rest of the areas are like a lot of dandruff, and the exact hair loss is back of his head, which I couldn't take the picture. So we'll just imagine a kind of a patchy hair loss with a lot of scaling at the back, right? So coal tar not given in this person because it is not psoriasis, right? Prescribe oral griseofulvin, right? It can be the answer for this because we are suspecting now. What we are suspecting? We are suspecting a fungal infection of the head. That is why it has been so inflamed and it has caused a patchy hair loss. But let's keep that aside. Next, send skin scrapings for analysis. Okay, let's keep that as a side as well. Refer to dermatology. We don't need to refer because there is dandruff, inflammation and a patchy hair loss. We can easily use our magnifying glass and see what the problem is and prescribe a topical steroid. Probably might not be necessary in this because it is only in one area that is inflamed, and most likely this person is actually having a fungal infection of the scalp. In that case, it has not got better. I mean, he has been having a lot of dandruff, and that patchy hair loss has become so inflamed, and one entire area hair loss is there. Always before starting treatment, try to do some skin scraping, see it under microscope, see if there is any fungal hyphae, fungal spores, and then start management. No need to refer to dermatology. Don't start oral griseofulvin until you get the differential diagnosis. I mean, until you get the diagnosis as fungus right in this particular case, right? Can somebody please read this quickly? We'll try to go through everything. Yeah. It's also very important, right?
34-year-old man, a 34-year-old man presents for the removal of a mole, where one of the body are keloid scars most likely to form. Sternum, lower back, abdomen, flexure surface of limbs, scalp.
Right, okay. So what you actually see here is, from the name suggests, it is keloid, right? Okay. So keloid scars, what are they? So everything is important. I'm telling you the MCQ points. It is a tumor-like lesions that usually arise from the connective tissue after a scar. I mean, whatever you make an incision, the scar comes from that connective tissue. It slowly extends. I mean, it's like a tumor-like projections, but not a tumor. And the most important thing that you need to know, that keloids are very, very common in dark skinned people, and it is very, very common in young adults, not elderly. MCQ. And the commonest sites, starting from the commonest to the lowest, is sternum number 1, shoulder number 2, neck, and then face is number 4, right? So here, then again, we know the options I told you. So sternum, because that is the sorry, the commonest site. And why does keloid usually appear? So keloid scars, you can avoid these keloid scars if you make the body incisions, the cuts, according to the lines of, you have heard this Langerhans lines. Just go and read. There are certain lines in your body. If you go across that lines, you will not get any kind of scars or keloids. So what is the treatment? Early in the I mean, early if the patient can present. Hello, yeah. Any doubt? Pardon? Okay, right. So early in the course, when the person comes to you, you can actually give intralesional steroid triamcinolone and excision. But they tell NICE guidelines says that excision is required, but you need to be very careful because it can actually cause further keloid scar, right? So very important when you make the incision, tell the patient to come back and see you and use triamcinolone intralesional as a first line and try to avoid to do a surgery on this to remove this because it can recur again, right? Sternum, okay. Can somebody please go through this, the question, please?
A 62-year-old man asks you to look at a lesion on his face. What is the most likely diagnosis? Keratocanthoma, seborrheic keratosis, actinic keratosis, basal cell carcinoma, pyoderma gangrenosum.
Right, okay. So this is not a pyoderma gangrenosum. Do I have a picture? Okay, I don't. The picture is actually in the. I think I've explained it to you previously when we did. I think you remember. So pyoderma gangrenosum, things you can get in the in certain conditions like rheumatoid arthritis or inflammatory bowel disease, where most likely in the limbs like the hands or the legs, you get a small dot like a nodule. It ulcerates and it becomes a huge ulcer. That is pyoderma gangrenosum. So this is not something like that because it has not got a bad, it's just a roundish volcano-like shape. It's called, what do you call this? It's a dome shape, right? What is dome? Dome is basically, you have seen Taj Mahal, right? The one on top of Taj Mahal. So that rounded shape is called a dome shape. So this is a dome shaped one. So basal cell carcinoma is not the answer because basal cell carcinoma just in the borders, the outside ring, the borders, it is so rolled in, and the center becomes flattened, which we call as a central crater. So this is also not the answer. Actinic keratosis. So actinic keratosis is just like a pre-malignant condition towards squamous cell carcinoma. It can occur in the face, but it is not so thick like this. This is something like a dome, rounded, but actinic keratosis is just a small ulcerated, crusty, just like a crust, like so when pus in the body becomes dry, how you get crust. So that kind of a crusty lesions on the face is actinic keratosis. And seborrheic keratosis is also, I think I explained it to you previously, blackish, small dotish, dot blackish mole is called as a seborrheic keratosis. So this is also not the answer. And keratoacanthoma is the answer. It is a benign epithelial tumor, most commonly in young people. And like I told, it doesn't turn into a carcinoma at all. It is not a pre-malignant condition. It initially forms a small nodule. Then that nodule becomes a small dome shape, like a Taj Mahal on top. That kind of a small dome-shaped lesion rapidly grows bigger, and whatever inside is nothing but a keratin filled inside. You don't have to do anything, no treatment. Spontaneously, it gets better in 3 months. Keratoacanthoma spontaneously gets better in 3 months. Usually, there is a small scar, but if it doesn't get better, then you do surgery, but it doesn't doesn't turn into a carcinoma at all, right? Okay. Can somebody please read this?
A 64-year-old man presents with a rash on his legs, which has developed over the past few days. He complains of feeling generally run down, but review of system is unremarkable. What is the most likely underlying cause? Vasculitis, erythema multiforme, necrotizing fasciitis, Kaposi sarcoma, venous eczema.
Right. So since I have explained almost all of these in the previous lecture, I will just give you a picture how this lesion looks like, so that when you're going through the previous one, you will get it. Everything will go into your mind. Right. So Number 2 is erythema multiforme. I think I have a picture after this. I'll just tell you and then I'll show you. So erythema multiforme is nothing but a small rounded shape and there's a small target. That means it's like, you see this bow and arrow game where they try to, send the arrow and there's a round and you target the middle. So that is called a target sign. So target sign lesions you get in erythema multiforme. Here it is only dotted shape. I don't think there is any targets. If you see below near the ankle, there is no any target signs. And then necrotizing fasciitis, no, because that entire fascia necrotizes and it's like opened up. This is not open. This lesion is not opened. And number 4 is Kaposi sarcoma. Kaposi sarcoma is, it can be just like this. It is a purplish color, purplish, big, huge, like a nodule-like tumors, which are usually found in patients of HIV, right? And venous eczema, no, because in this picture you see multiple dotted blood vessel-like lesions. So this is typical of vasculitis. Now I'll come back to the, so you just see this erythema multiforme. I think I've explained to you the commonest cause MCQ, the commonest cause of erythema multiforme is HSV, herpes simplex virus, and other causes I've explained. Just please go and read. I don't want to waste time. Next is necrotizing fasciitis. You see the entire area is necrosed and opened up. And Kaposi sarcoma, I told you, nodular areas which are purplish in color. Now coming back to the vasculitis. So the MCQ point that you need to know, there are so many vasculitis you have heard. Temporal arteritis and polyarteritis nodosa, those things are all vasculitis. You would have probably read from the other people, other lecturers would have taught you in medicine. I don't want to go more in that. I'm going to tell you only the MCQ point here. How do you categorize this vasculitis? You need to know there are 3 categories of vasculitis. If it involves the small vessel, it is called small vessel vasculitis. Then you get something called medium vessel vasculitis and then large vessel vasculitis. There are only 2 conditions which are causing large vessel vasculitis. That is your temporal arteritis and Takayasu's arthritis. This is arthritis. This is your large vessel arthritis, your vasculitis. Coming back to the medium vessels, only 2 conditions involve the medium vessels. That is your Kawasaki disease and polyarteritis nodosa. Rest of the conditions, like let's say inoxolin purpura, and then you have studied about this Wegener's granulomatosis, Churg-Strauss syndrome, Goodpasture syndrome. All these things come under small vessel vasculitis. So this is an MCQ. They will ask you what is large vessel, medium, small. I've explained to you. That's about it in this vasculitis. Right. Okay. Can somebody quickly read about this, please? Quickly, please. Yeah. Just get ready at the end of the MCQs for someone to read, Just read. That's
Timothy is a 4-year-old boy who has been brought to see you by his mother. She explained that he developed a rash with little spots over the upper lip 4 days ago. The spots have now started to burst and rescheduled in an orange crust. Timothy has no past medical history and no known allergies. On examination, Timothy is systematically well. He has an erythematous rash on the right side of his upper limb with a few visible vesicles and an area of golden crust. There are no blisters and no other areas affected. What is the most appropriate management? Advise good hygiene measures to aid healing. Prescribe hydrogen peroxide cream. Prescribe oral flucloxacillin syrup. Prescribe topical fusidic acid. Prescribe topical mifepristone.
Right. Okay. Thank you. So, like you see, this young child who has come with a orange golden crust-like lesion around the nose and upper lip areas. So this is very typical of something called impetigo. Very, very important question. Impetigo, which is very common in these children. So you have to know certain points about this. Very important points are, it is a superficial. It affects only the superficial layers, and it's a bacterial infection caused mostly by Staph aureus, but also can be caused because of Streptococcus pyogenes. Okay, so that is one thing. And it can be a primary infection, or probably it can be caused by a secondary infection like eczema. After eczema, you can have this problem. So secondary infection, and it is very common in children. And MCQ, it is very common during cold climate when it is rainy. Very important, right? This infection can occur anywhere in the body, right? Anywhere in the body, even the face, flexors, and it doesn't need any clothing. Even inside the clothing areas, anything can be affected, right? So spread, how does it spread? It can spread like from the discharge coming out of it, from direct person to person contact. It can go, or probably the bacteria probably can invade into the skin through very, very small minor abrasions in the body. And mainly when the hands are not properly washed, it can go through the hands. And the two and the two important features are, it is very, very contagious. It can spread. So school exclusion is needed until the crust is getting better. And the golden crust, or the yellowish crust, is very important. And coming back to the management, NICE guideline says 1% hydrogen peroxide is the drug of choice, topically given. Very, very important. Don't forget, that is the first one. And the number two is, if it doesn't get better with that, you can give topical fusidic acid. I just explained to you. And number three, if the person is probably not getting better to this, or if the child is an MRSA positive, use what is called, what did I tell? Yeah, topical mupirocin. That is the one. And what happens if it becomes extensive, huge area of impetigo, then you can give oral flucloxacillin. And if the patient is allergic to flucloxacillin, you give erythromycin. So this child, it is so minor, it is very superficial, very small, and just one or two lesions. You can give the second option, which is hydrogen peroxide 1%. That is the drug of choice according to NICE guidelines. Right. Can you quickly go through this, somebody?
A 22-year-old male presents to surgery due to a long-standing problem of bilateral excessive axillary sweating. He is otherwise well, but the condition is affecting his confidence and limiting his social life. What is the most appropriate management? Non-sedating antihistamine, topical hydrocortisone, perform thyroid function test, topical aluminum chloride, refer to dermatologist.
Right, good. So this condition, he is telling that, it's a long-standing problem, and mainly bilateral axillary sweating, and the hand itself shows that he's having the hand sweating as well, right? So this condition is called as hyperhidrosis. And can we give non-sedating antihistamine? No, there are no any reason. There's no itching or anything, so you don't give that. And topical hydrocortisone, it's a mild version where I told you, you use it in the flexures. It's not given here because there is no eczema. This is not an eczema. There are no any lesions, so you don't give that. Next, performing a thyroid function test, there is no use, because if at all, I mean, and one more thing, you can still think, okay, the patient is sweating. Why can't it be hyperthyroidism? See, in the exam point of view, the examiners are quite lenient. They are nice towards you. If at all that is the issue, they would give you some hint, like for example, heat intolerance or something like that. Since nothing is given, this is very likely towards hyperhidrosis and nothing to suspect hyperthyroidism. So performing thyroid function is also out of the picture. Referring to dermatology, no. As a GP, as a family physician, you don't need to refer these kind of cases. It's so easy. What you can actually do is first prescribe 20% of topical aluminum chloride. So this is the answer. Topical aluminum chloride is the first line, and the side effect you can get is a very, very minor, some kind of a irritation, skin irritation. And when do you refer to dermatology? If it doesn't get better with topical aluminum chloride, probably the patient needs botulinum toxin or certain surgeries like transthoracic sympathectomy. So these kind of conditions are the ones that you have to refer. But giving topical aluminum chloride for hyperhidrosis, you don't need referral, right? Can somebody? I think we did this. just with the picture itself, somebody can answer what it is. I just told you. So it's a third trimester, first pregnancy. Can we not waste time and anybody, just tell me what the answer is here.
Polymorphic eruption.
Morphic eruption of
Very good. Excellent. Excellent. Done. So atopic eruption, not in the abdomen, maybe in the other areas. And fembigoid gestation, the umbilicus is not affected. Psoriasis, the areas are quite not very common. And obstetric cholecystitis, probably it can be the answer, but this is only in certain areas, no? So if it is a widespread generalized itching, then we can think of obstetric cholecystitis, right? Yeah. Can somebody read these two, please?
A mother brings her 4-year-old boy to you with a burn. She said it happened yesterday and is not sure how it happened. Her best guess is he poured a hot beverage on his arm. She was going to bring him in sooner, but he said it was not painful anymore, and therefore she delayed the presentation. You notice a white lesion on his forearm that covers about 2% of his total body surface area. Next one, a 23-year-old woman present to you one day after accidentally sitting on a hot barbecue grill that was unknowingly put onto her chair. It was very painful, and on examination, you notice a patterned burn with blistering across the posterior thigh where her skin was exposed. The erythema surrounding the area blanches with pressure.
Right. Okay. So now we are dealing with something in the burns, in the skin. You know, burns is a vast topic. You have so many things, but I'm just going to concentrate more on your exam-oriented MCQ only. So what you need to know is just take the important words in the first one and the second one, and then I'll explain, and then we'll go back to the answer. The first one is the third line. Just see the third line. He said it was not painful anymore. That means the entire thickness of the skin is gone. There are no any nerve fibers. So think what it is. I'll explain it to you later. Next is it is very painful. Probably it is very superficial, right? Okay. The MCQ point in burns is they will ask you what are the degree of burns. You know, there is first degree, second degree, third degree, and so on, right? So starting from, you know, this epidermis, the first one is a superficial epidermal, which is the first degree, and that area, it won't be, there is no ulcer and it is not opened up. It is very reddish, very painful, and there is no blisters, nothing. So coming back to the second one, that is the second degree, it becomes a partial thickness. That means the epidermis is gone. In the dermis, some part of the dermis is also gone. That is your second degree. Here, what happens? Here, it is then again, redness is there, painful, and then blisters start to appear. That becomes a second degree burn. So that is your epidermis is also gone off, and the small part of your dermis is also gone. Now, your entire dermis, not the whole thing, but 3/4 of your dermis is also gone. So that is a partial thickness, deep dermis. So that also falls under the second degree burns. And here you have to know it is typically very white, patches like thing. And there are minor erythemas which doesn't blanch at all. And the sensation is reduced. The patient will have pain, but not much. That is your partial thickness. 3/4 of your dermis is gone, second degree. When do you call it as a third degree? That means the entire full thickness, epidermis and dermis, fully gone. It becomes brown or even sometimes white in color. No blisters and no pain, because the entire skin, the whole thing is gone off, right? So this is your this thing. Okay, so the number one, we know it is not painful anymore. So what it could be? Obviously, it is a full thickness burn, right? Okay, full thickness burn. And the other one I just told you is a superficial dermal. Okay, now we described what are the stages. What are the stages of the burns? That is one MCQ. Definitely, if at all you get something in this, you get one from that. So when do you refer to a secondary care? That's what they ask as a family physician. When do you refer to a secondary care? All the deep ones, like, you know, the deep dermal, that means The second degree, when the 3/4 of your dermis is gone, and or the entire, like what do you say, like full thickness, then you refer. That is one thing where you refer. Next, when the total body surface area in children, if it is more than 2% in children, and if it is more than 3% in adults, you refer. Okay. Any injury that involves inhalation injury, you take it off. I mean, in the sense, you try to send the patient to the secondary care. And any electrical or chemical injury, that also you refer. And any kind of suspicion of non-accidental injury, you refer. These are the only things that you refer to a secondary care, and nothing much in burns. These are the only important ones in burns. Right. Right. This is not that important. Just leave it. Okay, fine. Right. And yeah, I think we did this. Can somebody read this, please?
You see a 37-year-old lady who suffers from psoriasis for her annual medication review. Which of the following associated condition does NICE recommend she should be screened for every year? Psoriatic arthropathy, gout, squamous cell cancer, celiac disease, type 2 diabetes.
Okay. So you know that every year, why they say every year is basically in psoriasis, there are certain complications that the person will have. Number one, every year you should be very cautious about the joint problem. Psoriatic arthropathy is the number one that you have to be worried about first. And then what are the other complications? It's a very important MCQ. Cardiovascular system. They can have some cardiovascular problems like MI. Number two, hypertension, venous thromboembolism, depression, ulcerative colitis or Crohn's disease, and non-melanoma type of skin cancer. Non-melanoma in the sense squamous carcinoma. So these are the things that you have to actually look into the patient. So in these options, almost everything the patient can get. But the most important number one you should screen in psoriasis is psoriatic arthropathy, and then comes your cardiovascular, hypertension, and so on. Just keep everything in the mind, whatever I say, and we'll try to get the recordings and then listen to that again. Everything will go in your mind. Why I'm struggling so hard is I'm telling you all the points that you don't have to read dermatology at all ever for the exam at least. Okay. Can somebody okay, can somebody read this, please?
A 6-year-old presents to the GP with his mother,
Mhm.
who describes a stubborn patch of eczema on the boy's left cheek, which was worsening despite his usual emollient and topical hydrocortisone treatment. Overnight, the patch has become extremely painful and spread to his chin. He has had eczema since infancy, but is otherwise well. Examination reveals a patch of dry erythematous skin on the right cheek and a large, more erythematous patch on the left, extending to the chin. The area is hot and tender on palpation. Vital signs are normal. What is the most appropriate action? Oral isoclavir, oral flucloxacin, same day referral to pediatrics, topical clobetasol to affected areas, topical hydrocortisone to affected areas.
Right. So if you see this lesion, this child's face, right? I told you children usually have this kind of eczema starting in the face and then slowly it goes off. I told you that, right? So this particular case, why are we so worried is if you see this eczema, it also have small blisters, small, water-filled round blisters. What does it mean? That means this eczema has turned into something called eczema herpeticum. What does it mean? That means on top of a eczema, normal eczema, a person can have a severe primary infection with herpes simplex 1 or 2, which is life threatening. So eczema, somebody, even an adult coming with eczema and there are small blisters, be very cautious. It could be eczema herpeticum. That means a viral infection, a herpes simplex on top of a eczema. In that case, it is a potential life-threatening. You have to admit this patient for IV acyclovir. So you learned something, one important one called eczema herpeticum, right? Can somebody quickly go through this? And it's 11:10 now. So I thought of finishing it off in 2 hours. I think I have another 15 MCQs. And I don't mind even doing it again, because when you overload you with a lot of information, no, then you get confused and nothing goes into your brain. I probably need just another 1 day, but I don't mind doing it. No harm. So if you read this one and the previous one, and maybe if I do another one, these 3 lectures, just listen when you're traveling. That's it. Dermatology is done. You still have more, time, but I think what we do are all not very official ones, no, because I think we have a time frame where you're going to finish the MCQ. So I'm doing it as an extra. So I don't mind doing another one and finishing it off, because dermat is so important. And why I'm going so slow is I can just go through fast, but no point. I need to give you the important, relevant ones so that you don't even need to go and read again. So just let me know if you want another class. I can finish it in another one class. We can just, another 15 or 20 is there. So we can finish it off. Maybe we'll finish this as the last MCQ, and we'll probably do the rest on another Saturday or Sunday, next Saturday, Sunday. Okay? Right. Can somebody read this, please?
An 8-year-old boy attends the GP surgery with his mother. He recently injured his shin playing football, and his mother is concerned it may be infected. The initial injury was 2 weeks previously and described as a graze. On examination, you see a well-healed superficial abrasion on the skin with multiple small raised pink papules with a central dimple around the graze. The skin is otherwise not flushed and cool to touch around the wound. You also notice a crop of similar lesions on his stomach. His mother says the lesions have been present for about 6 months. What is the likely diagnosis? Molluscum contagiosum, chickenpox, Roseola infantum, Pompolix eczema, Staph aureus infection.
Right. This is also very, very important, because I'll tell you why. So that this diagnosis, I think I even explained to you previously in the last lecture. This is also something like a dome shape, like this, the top of the Taj Mahal, that kind of shape. So one we learned is keratoacanthoma, and this one is actually molluscum contagiosum, which is a viral disease, and it's highly contagious, and it will actually go by its own. Just a minute, just give me a minute. Yeah, sorry. So this is molluscum contagiosum. It is a one that is mostly affected in children, but also can affect adults as well. And it is not chicken pox, because these lesions are not vesicles, small crop of vesicles. Water filled areas are seen in chicken pox. But if you see this child is been having, if you see the last line, the mother says the lesions are present for more than 6 months. So obviously chicken pox doesn't, it's just an acute one, goes off. Number 3, Roseola infantum. So you get a condition in children, a kind of a viral, what do you say, small papules in the body. Roseola infantum, also called as 6th disease. That is just a viral infection. That is also not the condition here. And the 4th option is Pompolix. Do I have picture, by the way? 1 second. Yeah, I have a picture. Yes. So see, Roseola infantum, number 2, you see it is like a viral infection. It's called 6th disease, and it is caused by human herpes virus 6, HHV6, and that is just a viral self-limiting condition. So this is not the issue here. Pompolix, I told you, it is a kind of an eczema which is in the palms or soles, just like dotted vesicles in the palms or soles, right? Last is Staph aureus infection. What they actually meant in this child is impetigo. That's what they meant in this child, right? So if you see what they are actually talking about is, this is so important, is something called as Kobner phenomenon. What do you mean by Kobner phenomenon? Let's say a person is having lesions in the hand. Somebody tries to scratch this, or the person falls onto this, and you get trauma. So repeated trauma or scratching after repeated trauma in that lesion multiplies, it aggravates in that same area, it becomes more after the trauma. That is called Kobner phenomena. It's so important. I also got this question for my MCQ. You might also get it. It's so important. They will ask you, what are the conditions you can get Kobner phenomena? Psoriasis, very important. In a psoriasis, after scratching or after they fall, trauma, it can aggravate, it increases. That is number one, psoriasis. Vitiligo, viral warts, lichen planus, and molluscum contagiosum. These are the 5 things. I repeat: psoriasis, vitiligo, warts, lichen planus, molluscum contagiosum. These are called as Kobner phenomena. After repeated scratching or repeated trauma, these multiplies in the same area. That is called Kobner phenomena. So I think I have another 15 or 20. If you give me another maybe 1 hour and 45 minutes in the next on next Sunday, I don't mind finishing it off. So you don't have to open dermatology at all. I'll try my best to talk to the organizers to get the recordings and the video, whatever the thing, so that you get an idea, and just read this or listen to this only when you're traveling or doing something else, because I have explained everything. You don't have to read or do anything. Okay. So there are some doubts here. Is that, I think it's, yeah. Shall I quickly go through the doubts? Okay, coming from the last one. Okay. Somebody wants a please arrange, and okay, I'll just go with one question which is given here. Sir, does oral and local antibiotics not be combined in general or only in acne? See, it's like this. What the NICE guidelines says, in general, giving both are actually a problem, because that's why in any condition, like let's say in local conditions like local wounds or anything like that, we combine, right? That's what we do. But NICE guidelines particularly tells about acne, do not combine both in acne. But other conditions, it depends. Like let's say the person is having an abscess is removed, you do the dressing and you give oral antibiotics, you balance it, but never try to abuse or give it for a longer time. Okay, so that is one thing. I know there are a few questions. I'll try to mark all these things, and shall we discuss it in the next thing? Just a minute, I'll try to take a picture of these things, and so one more class is enough. So that's it. That's entirely dermatology. 100% you will get some, the 5% I told you, out of the 100% of your questions for the exam, 5% is dermatology, and definitely you will get something from this. Take a picture and okay. So all these doubts are just quite simple only. So just I'll answer another quick one. Someone wanted to know what is the difference between Tinea cruris and Tinea corporis. Okay, see, Tinea is dermatophyte, that is a fungal infection. So why they use those names? To signify certain areas of that fungal infection. For example, now when you get this tinea round lesion on your face, it is called as tinea facies. When you get it in your nails, in your fingers, basically, you call it as tinea inguum. That is unguim, inguum. When you get it in your groin area, you call this as a tinea cruris. When you get it in the feet, legs, you call this tinea pedis. And the rest of the entire body, it's called tinea corporis. So that one, the rest I will actually tell you in the next class. So hope it was helpful. So we will, we will meet on, if you have a group, just message the group whatever days you're free, either a Saturday or a Sunday. Another 2 hours is enough for me. So make sure you go through the first lecture and this and the next third, and you're done with dermatology. You're all set to give the exam. Okay. Good luck then. Bye.
Thank you, sir.
Okay. Bye.
Thank you, sir.
Okay.
Yes, sir.
Okay. Bye.